This week on the BackTable podcast.
The team needs to comprise of individuals who are, again, passionate, motivated, and are champions of the respective positions within the PE team. And if there are not any physicians who are part of the team that want to manage that other aspect, then it behooves the interventionalist to learn and do it. My IR partner, Chris, he will call me often. Hey, I can't really, evaluate the echo so clearly. Can you look at it and let me know what you think? Or, upon discharge, he will say, all right, I will refer this patient for you for follow-up because the patient has RV dysfunction. And, I'm not sure what I need to look at 3 months. So do you mind seeing the patient follow-up? And vice versa, I don't remove filters and I'll send the patient to him. So that multidisciplinary team comes into significant advantage when you're thinking about not only initial stages, but obviously long-term as well.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. First, a brief message from our sponsor.
A decade ago, RapidAI harnessed AI to revolutionize stroke care. Now they are bringing that same innovation to aneurysm and pulmonary embolism. This AI-powered, clinically driven workflow platform enables care teams to accelerate triage and treatment decisions and improve operational efficiency to achieve better patient outcomes. RapidAI, where AI meets patient care. Now, back to the show.
Today, we have a great episode lined up for you. We will be discussing the essentials for building a successful PE team. Today, we have an interventional cardiologist, Dr. Rohit Amin. We've previously discussed this topic about a year ago with Michael Brazza hosting. He had interventional radiologist, Dr. Karen Gonzalez. This was episode 196 for those of you who want to go back and listen. And they talked about building a PE team, but it was more in the academic setting at Jefferson. And today we thought it'd be good. It's been about a year since we did that. And Rohit is in the private practice world and has a more kind of a unique PE response team that's been built. And so we wanted to talk to him about the challenges he faced when building this in the private practice setting, covering a larger geographic area, and how current technologies help streamline that care for better outcomes. Welcome, Rohit, to the show.
Thanks for having me.
Yeah, man. So I always like to start these out with just like a quick intro. Tell us where you trained, where you're at, what your practice looks like. I'll have some follow-up questions. But yeah, start where you trained at.
So I did my general cardiology and heart failure transplant training at the Ochsner Clinic in New Orleans. It's a pretty robust interventional program in that they were very cavalier in the early days with both endovascular intervention. In fact, they were probably the first group of formal interventional cardiologists that held a multi-year course known as peripheral angioplasty and its jazz. And then fast forward a few years later, they were the first group of interventional cardiologists that sort of moved into the space of stroke intervention through a grant with the American Heart Association. So had a fairly unique sort of perspective and viewpoint on the approach to very wide variety of interventional cases and not just dedicated to coronary. That kind of fueled my dedication and desire to be in other spaces. And so from there, went on to do my interventional fellowship at the Detroit Medical Center. Had the luxury of working with some really important mentors who really set the stage for my next phase, which was obviously practicing private practice interventional cardiology fellow.
Yeah, so you moved from Detroit down to Florida, right? And you're in the Panhandle area, is that right?
Yeah, so I moved here in 2012 after fellowship. I actually got recruited by a faculty member from the Ochsner Clinic who came way this way after the hospital decided they wanted to start their own program. And for many of your audience who are interventional cardiologists, in the 2000 era, there was a big shift of cardiology groups being purchased and bought by many of the hospitals. And so coming out of fellowship, it was very daunting. to hear about joining a private practice group and that not knowing after a year or 2 or 3 years if you'll be part of that sort of still that makeup of the group if been purchased by a hospital. So I chose to take the safe route, and obviously a former faculty member and mentor of mine brought me down here. It was not my first place, just being geographically area, but I had the opportunity to really practice my skill set, everything I've been trained to do. And that was obviously a very important piece to what shaped my career for the next 10 years of being here and being able to really flourish in a lot of other spaces and facets of interventional cardiology. So for the young, budding interventional cardiologists or radiologists out there who are looking for their first job, of course, being in a big metropolitan and cosmopolitan city is always exciting, but making sure that you have the ability to practice your skill set. And for most of us proceduralists, it's incredibly important to have a mentor that you can trust. There's inevitable cases in the first 2-3 years, and even now, 10 years later, you need a confidant, someone who can support you through the thick and thin. It can be an isolated island by yourself if you're in a practice or an area where you don't know anyone. And it definitely makes it a big, tremendous difference in currently my practice.
Yeah, it's so true. And probably for job retention as well, just to have those mentors, close and at hand. So how big is your group?
Yeah, so when we started, there were 4 of us. I was the 4th guy that joined. Now we're 12.
Wow.
So pretty exciting. And we're looking for 2 others. And the Panhandle and most of Florida has really seen a surge in relocation, particularly to the pandemic the last 2 years. So exciting time.
Yeah, you're right. That whole Panhandle area is not only beautiful, right, but I've seen a lot of growth in population. Because I think you and I talked about this before. I went to med school at Tulane, and so we used to drive over there I graduated in 2007, so we drive over there in the late 2000s, and then it had been a while since I'd been down there because we went up northeast for training, and then by the time we came back down south, it was 2013, and we would drive up. We go down to Rosemary or Seacrest or Seagrove, and the growth down there was incredible. But you're more in the Pensacola area, right?
Yeah, I'm in the Pensacola area, so we have the same beaches as 30A and Destin do. Yeah. We like to say we have more of an identity. We have locals that actually live here.
Yeah, totally.
So, it's also been a nice part to see this city flourish into what it's become.
Yeah. So it sounds like you have a very robust endovascular practice, not just cardiac work, but peripheral work. And then it sounds like PE work, which is going to be our topic for today. How did PE interventions become like another major focus of your practice? Was it always that way? Was it even part of your training, or is this something that kind of came across in more when you became an attending in private practice?
Yeah, so I think like any other budding interventional cardiologist, has spent a many number of years of training and looking for the opportunity to create a niche for themselves in a community practice. It was just part of the repertoire to seek training, education, and then hopefully being able to treat those patients. It was a sort of a natural progression for me. In my first 2 cases that I were experienced in terms of interventional PE was in cardiology fellowship. I had done a year of heart failure and a year of interventional, and in my opinion, those are the best skill sets to really manage these patients, because after all, people die with PE secondary to RV failure. It's a cardiovascular compromise. So it was just a nice little opportunity to get into. When I moved here in 2012, there was the interventional radiologists who were part of a big private practice group here, who to this day, along with their vascular surgeons, have the lion's share of the endovascular work. I started to pick up a few consults here and there on DVT therapy and a couple PE. At the time, it was very rudimentary in terms of management of PE. It was just a catheter-directed thrombolytic. So in terms of skill set, there was no separation between myself and the other folks who had been participating in it. But I wanted to go one step further. I wanted the awareness to be sort of available for everyone else, as I noticed not only my partners, but even our oncologists and even pulmonologists were not aware that this sort of modality existed. And so actually through a serendipitous event with the ECHOS rep, he mediated a discussion with me and an interventional radiologist who is now my co-director after now 8 years of the service line. And we came together over a couple beers and decided, you know what, let's just start this together. At the time, there wasn't a formal service line, so it took, and it still remains, a lot of groundwork on our behalf of having to pitch this to the administrators, then the medical executive committee, multiple meetings at 6:30 in the morning discussing why we thought this was a good idea for the hospital to carve out a formal service line, and then, of course, the awareness piece. So through that, the awareness piece was a number of both, formal CME programs and informal CME programs, from grand rounds to teaching the house staff to morning report to a bunch of awareness meetings outside hospital grounds at usually the restaurants sponsored by the reps, such as World Thrombosis Day, VT Awareness Day. We went from, I remember the first meeting, we had one person, and we have a big event coming next week for World Thrombosis Day, and we have, I believe, 45 RSVP. So very excited to see the growth.
That's cool. And so you mentioned part of the challenge was just this awareness piece where you're just like, you're on the front lines, you're seeing these patients come in, and you're seeing that the treatment at the time, the catheter-directed lytics wasn't really, it may, let's not say it wasn't effective, but there could be improvement. And I remember back first starting, in practice, that PE care definitely seemed chaotic and uncoordinated. And it sounded like you had another progressive thinking IR to team up with, which is unique and really neat to see and hear about. What about did you have to go out and like capture other advocates, not capture, but recruit other advocates like, the guys in the ICU, the pulmonologists? Tell us a little bit more about that, like getting some of the other specialists on board.
Yeah, good question. So initially, lots of pushback, particularly amongst our pulmonologist at the time. This is, again, take you back 2013, where to some degree, their chest guidelines are sort of not advocating, interventional therapy.
Yeah.
But back then, the paucity of data was even more than it is today. And so I think it was sort of another sort of narrative for the pulmonologist to say, okay, we have another cowboy interventionalist who wants to do another procedure.
Right.
And it was our intention to not just provide the coverage or management of inpatient, but it was also our intention to also provide service for longitudinal follow-up, which I hope we will probably pick up as we move on, which I really think was the impetus for our growth. But thirdly, and I stress this a lot in the consultative meetings I have with other sort of community hospitals, part of the Ascension Network, is that you have to have a champion. The champion should not just be about interventional therapy. It should be also about anticoagulation management. That's a huge nuance in itself that doesn't really get recognized in the PERT concept. And sometimes we don't have fellow hematologists like we had in our situation who are excited to be part of it. Nor do we have the pulmonologists who felt that, aggressive management, whether it be at the time catheter-directed thrombolytics or some form of thrombectomy, was appropriate in these patients. And, we had a couple discussions, and then my partner and I decided, we'll just move this without them. And perhaps with good work and good merit, they'll come on board and the service line will flourish. And fortunately, it did.
What were your main resources at the time? I know the PERT consortium formed around 2012 or so, I think. And that's when the first PERT teams that were being organized in the nation. Did you guys go visit another facility, or did you go to a conference, or what were your main resources at the time to kind of put that workflow together and build that team out?
Yeah, basically it was Endovascular Today journal, man. I read one of the articles, Endovascular Today. I think Kenneth Rosenfield has copyrighted or has the rights to the PERT team. And so, I just thought it was another opportunity. I've always been very ambitious, as it was an opportunity to bring this down here, and I thought it'd be very neat to have this in our area since there was nothing like it. Of course, at the time, I had experience from fellowship that was also just in the infancy. So I really didn't have a proper, blueprint or roadmap to really implement like we did in other facets of training.
Sure.
But my partner who performed stroke interventions, I performed STEMI care. It was very similar. You bring a multidisciplinary approach on the premise that timely care is important, knowing the nuances of which patients need intervention, which not at the time. Again, the details were not as robust as they are now. And having access to a radiology suite or cath lab facility suite was also incredibly important. And so I think from each of our background and what we did actively already in that space, it just, again, was a natural progression for the both of us to start this program from the ground up.
Yeah. And out of curiosity, how big is the IR group that works with you guys, like alongside you guys?
Yes. So we've gone through some changes recently in the last 2-3 years. We had a 3-man IR private group that was part of an 8-man vascular surgical group that encompassed most of Northwest Florida, 3 OBLs and so forth. They were a giant group. And then the hospital made some changes and they brought in, I think it's the Rad Partners group that they're here.
Okay.
And so we have 2 IR, I think they flip around 2 to 3 IR guys now. Those guys are, they come from very reputable, well-known programs, and they're not part of the formal PE team. We've had some discussions and things haven't just worked out to where we wanted. So we're kind of just still myself and the original partner.
Oh, so it's just the two of you on the PE team.
Yeah, man. So one of the things I always get from my partners or friends are, how are you doing STEMI, which is also 1 out of 2, and how are you doing PE, which is 1 out of 2? Man, it takes a lot of work. I mean, so that for those folks who want to start to be part of the team, it's obviously now things are dramatically different than it was in 2012, 2013, in that no one is aware of this. No one even understands there's an algorithm. What does this mean about interventional therapy? I mean, including my own cath lab staff and few of partners at the time were confused in why I was meddling in this field and why this was important. Now there's such incredible technology, with the AI, and then there's obviously all kinds of clinical data and guidelines that has really helped propel the field forward. And in fact, it's funny, last week, I had a discussion with our service line administrator, and she came to me. I haven't really met or talked to her in a long time. She came to me and said, "Congratulations on your 200th case." And I said, "All right, 200 case." And she said, "Yeah, 200 PE case. That is amazing." As she comes from Jacksonville, and that in their area, they have 3 Ascension hospitals, and not a single interventional cardiologist or an interventional radiologist has developed a team. So it's been a lot of hard work. I'm very proud of what we've accomplished, but we've been able to get to a point where now we're starting to get the notoriety and the support that once we did not have in the initial days.
Yeah, I mean, and that highlights the number one, thing about building a PE response team is you got to be committed. Right? It's a lot of work, and you got to be dedicated to this disease process and these patients, because you can't just dabble in it, right? You got to show up. You got to be there for those patients and for the rest of the team. And so, I've been invited to a PE response team in the past, but the problem was it was at a hospital where I didn't really go to very often. And so I respectfully declined, but it's one of those things where, and then I went back to the cardiologist later to ask him what happened. He said, I couldn't get anybody on board. He's like, I can't do it by myself. So it's one of those things where it really takes true dedication and passion for those patients. And so yeah, kudos to you guys. 200th case. That's impressive, man.
Yeah, Aaron, you're right. The passion and dedication, that's incredibly important. You have to be intrinsically motivated to really do this, just like in obviously any other field. But this is different in that for many of us, we didn't have any formal training.
Right.
No one told us, how do you work up intermediate risk PE? What does this mean? How do you use this device? How do you choose between catheter-directed thrombolytics or suction bore thrombectomy, large bore, and now very large bore. Those are all facets that you learn on the job. And for many of us who are already busy doing everything else, to add this next layer does take a lot of time, outside work to learn the homework and do all the due diligence and get your hands on every article and journal and reach out to the experts and so forth. And that really propelled it. And, my partner and I, although we complain about it, we never received any call pay for all those 10 years.
Yeah.
So, but it's rewarding. I tell my partners to this day, I do carotid stenting and do STEMI and some other things in interventional cardiology, but management and treatment of PE is incredibly rewarding because it's instant or sometimes immediate gratification, and patients feel significantly better. And in the cardiology space, data is all about mortality reduction, not so much morbidity reduction. But in the PE space, when people can just simply breathe and be able to walk around, that's an incredible accomplishment. And I'm still surprised, even after all these cases, I'm still surprised sometimes on which patients respond, which patients don't, but how quickly they respond. So yeah, it's been a fun ride.
Well, I've got two follow-up questions to that. One is going back to, you said originally there was the ECOS rep who approached you guys and said, hey, I think there's, an opportunity here. These patients are going a lot of times untreated. What kind of support did you get from industry, throughout the years? And now we've seen more companies dedicated to PE treatment, but how have you seen that really help the program?
Mm-hmm. Yeah, industry, the vendors, the reps have all been incredibly instrumental, I think, not only in our program, but I know multiple other programs and also nationally. It's propelled the field forward in many ways. All these recent clinical trials, although not, the standard, double-blinded, randomized, multi-center trials, mostly registry-driven, and they have its own shortcomings. But without their support of evaluating these patients, that we would never even got to this point. So yes, this industry support has been incredibly helpful. And for us, the irony is the ECOS guy who put us together and had the meeting, after that, I think 3 months later, I never use ECOS catheters because once again, I saw a article in the Endovascular Today and it had a 510K approval for Inari. And I literally did a phone call, left a message, and I got a phone call about a week later, and I started doing my first case and part of the first registry. The first case took us 2.5 hours. And then, six other cases afterwards. I would say, success. I would not even define those cases success to today. Yeah. And that just tells you how much we've learned from both the interventional piece, which is a whole nuance itself. And so, it's been incredibly supportive.
Yeah, Inari is one of the, and this episode's not sponsored by Inari. Inari has sponsored prior episodes, just full disclosure. But I actually am not I rarely treat PE in my practice. But Inari's done, just observing them, what they've done over the years, an amazing job of just training physicians up on this procedure and going out there and really providing a lot of education to docs around the disease process, as well as just getting their hands on the device and getting the opportunity to scrub with docs. So yeah, I think it's just a great success story, and it has led to better patient care in my observation. Again, I don't even do these cases,
Yeah, no, disclosure, I am a paid consultant, key opinion leader for Inari. So yes, it's easy for them in that space because that's what they're focused on, which is VTE management. And, Penumbra's done an excellent job as well. And they're helping lots of other physicians also grow, including our practice as well. And there's also other companies in the space and new companies in the space. So I think collectively they've done a tremendous job to really help propel the field forward for all of us. And most importantly, the patients benefit from all this data.
Yeah. And obviously it's going to continue to evolve, and we may even be still early stages with devices and how they're being used. Now, a brief message from our sponsor.
A decade ago, RapidAI harnessed AI to revolutionize stroke care. Now they are bringing that same innovation to aneurysm and pulmonary embolism. This AI-powered, clinically driven workflow platform enables care teams to accelerate triage and treatment decisions and improve operational efficiency to achieve better patient outcomes. RapidAI, where AI meets patient care. And now back to the show.
Let's jump into like how your PERT team functions. I did want to one more follow-up question to what you were saying before is for the uninitiated in our audience who, sometimes we have med students and trainees, residents who are listening to the show. What happens if a PE is left untreated? What happens to these patients long-term? Just give us an idea of that and why we do this. Not just death, right? With, like you were saying, like right heart failure, but what happens when they have this CTEPH picture?
Yeah, I think probably be best to discuss and take one step back in the whole sort of macro view of pulmonary embolism and understand it's a spectrum. And the spectrum includes low-risk folks, and then the massive PE folks, and then in between, which are these intermediate risk of patients. And that's kind of what we're trying to all figure out is which of those intermediate risk patients should deserve more aggressive therapy than just anticoagulation alone.
Right.
The low risk patient's pretty straightforward. It's anticoagulation. However, I would make a comment on this. It's not all anticoagulation has equipoise. I see this often here with the house staff where we'll be consulted for a patient with PE. And by the way, another little addition to our discussion of how we started the program, we take all comers, and even now, all comers, meaning all consults of VTE, both PE and DVT, get directly to the on-call physician. And so we're seeing patients who have posterior tibial vein isolated DVT to chronic, quote unquote, debris of left common femoral vein to patients who have segmental PE. So we are not excluding any of those patients because we understand that maybe our orthopedic colleagues or our hematology colleagues or the urgent care down the street, they may not know the approach and management of this particular patient. And so I think being well-versed in the pharmacological management and knowing that data is incredibly helpful, as it is to have a place for these patients to follow up. As we all know, primary care physicians are overwhelmed. They're unable to see these patients in a timely fashion. It's very easy to, send a prescription for one of the DOACs and you get 30 days for free, but they show up then after 30 days and where is the rest of the therapy? So that is a huge piece to the team as well that, I really pride myself on. And I think that's what separates our practice from the PE standpoint, DVT standpoint from the others, in that we take all comers and help to support any question that our referring physicians have. But going back to the main outline, the question is, if you leave these untreated, what happens? Well, astonishingly, submassive PE in the, seminal trials, PETO, showed there was a 5% risk of mortality between the high risk and the low risk category, which meant anticoagulation alone. And that was really the impetus to propel all the now device-based trials for that specific group. And how do you differentiate and find those groups of patients? Unfortunately, we have a differing definition, and it's very heterogeneous amongst the three guideline committees: American Heart Association, European Society of Cardiology, and American Association of Chest Physicians, in that they define RV dysfunction differently. One may define RV dysfunction as just the anatomical criteria of greater than 0.9 from RV to LV ratio. One may require the RV size as well as a abnormal biomarker, whether it be troponin or BNP. And so, unfortunately, that data becomes a little murky when we say, well, what happens? We know, at least some of the data has showed us, the iCopper trial, which was done way back in the day, at 30 days, the mortality for submassive PE is about 14.5, 15%. That is higher than non-STEMIs. And that statistic is important. And when I'm discussing this with other physicians and so forth, that kind of raises their eyebrows and how deadly this condition can be. And then the sequelae down the road, 3 to 6 months later, or maybe even a year, could be either this new entity we're beginning to learn is called post-PE syndrome or chronic thromboembolic pulmonary hypertension, CTEP, which falls under group 4 WHO classification. But fortunately, for those groups of patients, it still remains less than 1%. But for those patients who do develop CTEP, that's a very debilitating condition. In some respects, you have to have surgical thromboenderectomy for the treatment. Now, there are some physicians who are now in the space of balloon pulmonary angioplasty, but that's still, I believe, in its infancy. But there's a significant sequelae both at 30 days, 2 weeks, 30 days, 90 days, and then obviously long term. And believe it or not, it carries a higher mortality than non-STEMIs.
Yeah, thank you for summarizing that for our audience. And I want to use that as a stepping stone towards basically what, like when a patient is identified as having a PE presenting, let's say in the ED, walk us through how your team is activated, how that works, what technology is being used.
Yeah, so we are starkly different from the now traditional definition of a PERT team, in that we don't have many physicians on the team formally. As I mentioned to you before, initially we had a lot of pushback and not much interest, and so we kept moving forward. We now have had a number of both IR physicians, pulmonologists, and now recently one of my cardiology partners who wants to be part of this team, which is be exciting because that will be bringing in sort of a new sort of lens and allow the team to grow even further. But it's very simple, and I'm kind of embarrassed to say how simple it is. It's basically we have an algorithm. The algorithm has the ER physician or the hospitalist physician to evaluate the patient. If the CT scan shows proximal thrombus, we are notified.
Okay.
If the patient has non-proximal thrombus, no troponin, normal hemodynamics, after business hours, patient gets admitted to the hospitalist team. Immediately, an echo and venous doppler are ordered in all patients stat. Our echo team has now been well versed into do a special, what we call a PE protocol, in that we do a number of evaluation, risk stratifying tools of the RV. Because at the end of the day, if it's not massive PE, your job, our job, is to evaluate this patient for submassive PE, i.e. RV dysfunction. And other than size, which can be simply done, there are a number of other factors. One is called TAPSE, TAPSEI, which is probably the most robust proxy of RV dysfunction. And just for the audience, if you're curious, less than 16 millimeters TAPSE, which can be, by the way, measured in any in any echo lab, doesn't have to be anything academic. It's very straightforward. Can be measured, can give you a good estimate of what the RV is doing without the dilatation piece. Because over the number of years anecdotally, and now discussing with other physicians around the country at meetings, I think we're going to start moving into a different direction in that RV size is not the entire answer. Many, many patients have RV dysfunction without having RV dilatation. Many, many patients probably do better with catheter-directed treatment strategy if they have pre-existing LV dysfunction, as they have poor cardiopulmonary reserve or some other cardiopulmonary compromise, and they probably deserve a more aggressive management. Of course, all this data is being collected, but from my experience, that's kind of the approach. And so as the patient is being evaluated with echo and venous Doppler, every patient will receive some form of heparinoid, whether it be Lovenox or heparin. In my opinion, I think Lovenox still is the preferred modality, as you don't have these waxing and waning of factor 10A when you typically do the IV heparin dosing, when there's a delay by pharmacy or the nursing staff when you have to up-titrate the dosage. Obviously, heparin becomes advantageous in those patients that may come in with coexisting GI bleed or anemia, or we have a lot of big trauma centers, so that obviously plays a factor. But generally speaking, Lovenox. And then in the morning, we receive a consult just like any other consult was to receive, and we evaluate that patient that morning. And typically, if it falls under the submassive PE, we are going to do a procedure that day. And we pride ourselves on that turnaround. It is something that myself and my partner test to, and we keep each other honest with the length of stay and the treatment modality. If we have patients that sort of fall outside the traditional definition of submassive PE, but not necessarily low risk based on the aforementioned findings on echo, we allow for 24 hours of anticoagulation. The following day, we do an ambulatory road test, assess them for hypoxia, tachycardia, near syncope, their subjective sensation of dyspnea. And if it's not a segmental pulmonary embolism and it's still some proximal thrombus, even non-occlusive, we will then perform a catheter-based strategy. Now, that doesn't always mean interventional. What I mean by catheter-based strategy is I'm going to risk stratify that individual with the hemodynamic right heart cath.
Got it.
So I'm going to, evaluate their PA pressure, PA sat, and evaluate their cardiac index. And that's another sort of aspect in this entire management of PE. We have number of patients of normotensive shock. And if there's a couple of take-home points to the audience listeners, this would be one. Again, normotensive cardiogenic shock. What does that mean? Well, that means is you're at normal blood pressure. You do a right heart cath, and right heart cath, the cardiac index is 1.8, 1.9. Anything less than 2, 2.1, 2.2 is considered abnormal. Now, maybe the natural progression of anticoagulation and time and patience may help overcome this with just the conservative strategy per se. But if that patient just did a road test and they were hypoxic and they had near syncope and there's proximal thrombus burden, again, not segmental, I'm going to go after that particular patient and treat them with thrombectomy. And that helps me sort of guide my management in those particular patients. Recently, through the whole, the contrast shortage, I started to use IVUS and almost did a minimal contrast procedure, almost 5 cc's at times. I don't usually do a preoperative pulmonary angiogram, but the IVUS helped me delineate a lot of the findings if there was present of thrombus in the proximal pulmonary arteries or not. And that helped guide me with therapy.
Thank you for describing your algorithm there. And I was curious to know, in the early days when it was just you and your IR buddy, should we give him a name or just call him IR
Chris
buddy?
Bosarge.
Chris Bosarge. Shout out to Chris.
Shout out to Chris.
When you guys were originally starting, were you scrubbing all your cases together just so that you guys were doing, kind of forming that similar, technique so that you had similar outcomes, or do you consider yourselves like doing things just your own unique ways? How did you guys? I imagine you want consistency and to know that you guys probably mirror each other in your approach. But tell us a little bit about that.
Yeah, that's a good question. So one of the advantages of having a multidisciplinary team, particularly multidisciplinary in the sense of interventional multidisciplinary team, I think I want to specify with that. The IR guys have such a unique set of also catheter skills and techniques, and they've been in this space much longer than we have as interventional cardiologists. And my senior partner, Chris, has definitely been doing this for much longer. So in the early days, it was just about discussion. As he was busy, I was busy. But when I got in a situation where I didn't feel comfortable or where to park the Ecos catheter, where to place the wire in the early days, I certainly would call him and he would be gracious to come up and take a look and say, yeah, I'd leave this, or nah, why don't you do this, or why don't you leak some TPA here, or put another catheter on this side. Then that sort of evolved into now the sort of large bore catheters. And so, interestingly enough, he comes to me and says, hey, I need to know how you places get access for large bore. How do I get up to the RV? What should I worry about? What about this ectopy? And, it's kind of been sort of a nice sort of collaborative, complementary skill set that we both sort of work off each other. And, once a week or so through our VTE coordinator, who's been incredibly helpful to manage most of the stuff behind the scenes, we'll send pictures to each other about what thrombus load we're able to remove and what he did and what I did and what I could have done and what he could have done. And we do discuss those cases from time to time.
Yeah, so that's a great point. Is how do team members, you and Chris and other care coordinators, how do you communicate during the workup and management? Is it via some novel software application, or are you guys just texting or WhatsApping each other?
Yeah. So yeah, I mean, we're still old school, so we're just doing the text back and forth.
Yeah.
But as I was mentioning to you before, if one were to start now and cultivate a PE team in a community setting or even the academic setting, the academic setting is a little different in that they have the luxury of having fellows, see these patients 24/7, talk to their attending on call. In the community setting, whether it be hospital employed or private practice, now you have technology, and AI is gonna definitely scale things in a whole positive direction. And this is one attribute that's really begun to implement. I think will be very valuable. We currently do not implement it, but we are working with RapidAI, one of the 3 AI companies in the space. Our stroke team uses RapidAI, and they are very happy, and every one of the members of the team, including Chris, my IR partner, has felt that this is a night and day sort of management now, in both not only evaluation but also communication among the care members of the team. And I think that will also probably very much parlay into our PE protocol. Maybe not so much within our own hospital, but our outlying hospitals will be incredibly important. I think, COVID had a number of silver linings, let's say, that came across for our PE team. One of them was the sheer volume of patients that were transferred to us. And simply because we were a larger hospital in the area, 600 plus beds, and willing to take anyone who needed to be transferred. And many of the outlying hospitals were full. And so for their normal general medical issues, including PE, a lot of the ER physicians would reach out to our central operator and call for the ICU doctor for their treatment of a patient who has PE. And they were surprised that they're in contact with the PE team physician, which is myself or the eye interventional radiologist guy rather than the pulmonologist. And from then, we were able to get and receive many other transfers. But not all transfers need to be transferred.
Right.
So I think where this AI piece, at least for us, will be incredibly helpful. It'll be a win-win-win for everyone. The referring hospital doesn't have to have that leakage of patients where they could hold on to our center that don't need to be treated. The patient and his family members don't have to travel so far or pay for that separate ambulance ride to come to our center. And thirdly, we are also limited in beds, and we don't need to occupy a patient with low risk PE in our hospital center that can be managed, with anticoagulation. So AI will definitely help mitigate those issues, and certainly for a starting program or looking to take it to the next level, I certainly think these AI software packages will be incredibly important. But currently, as we speak, it's simple. We post the images of the pre and post pulmonary angiogram, along with the hemodynamics and the thrombus. And through that gets sent back to the referring group of physicians, usually the hospitalist and the resident or the ER physician. And, we get the wow and the exclamation marks and all that kind of stuff. And that's kind of how it propels the field.
So we walked through your algorithm a bit. I do want to talk a little bit about, there's been this major shift. We already kind of alluded to it, and we talked a little bit about Inari, but major shift in endovascular treatment of PE with the growing availability and efficacy of, the large bore thrombectomy catheters. It sounds like you're using these over catheter-directed thrombolysis and maybe even ECOS, but or is catheter-directed thrombolysis and or ECOS do they still play a role in your practice? If so, when?
I would probably receive some criticism for making this comment, okay? But I see no role in catheter-directed fibrinolytics in the management of PE.
Yeah.
And the reason I say that is because how do we really know the duration of thrombus? It takes just 7 days to start to develop 20% collagen, 14 days, 80% collagen. And anecdotally, after using these large bore devices, you remove, organized, fibrotic, chronic thrombus. I'd be very difficult to believe that that TPA, even now the new modality is rapid treatment of TPA, 2 to 4 hours, would really improve that thrombus burden. And just like, the management of both, STEMI and, critical limb ischemia now and stroke, it's time to now move into the next facet of technology, which is using these thrombectomy catheters. It also plays a huge advantage in terms of management afterwards. I remember, when we used to perform, acute limb ischemia or even DVT management with, the TPA catheters and so forth, and you bring the patient back the next day and you didn't really see a good result and staff is upset with you and frustrated, go back to the ICU, hang another bottle of TPA, and you're like, what are we doing here?
Right.
So I think we're now gotten to a point where honestly the thrombectomy catheters are the next phase, and they should be hopefully routine management for the catheter-based strategy.
Yeah. And kind of along those lines, because you just mentioned the DVT stuff, we kind of walked through your standard algorithm for maybe a more straightforward case, but what about patients who also have extensive DVT that might they might normally undergo intervention? Do you do that at the same time as the PE intervention, or you wait till later?
Mm-hmm. Yeah, so it kind of depends on a number of factors. So in general, if a patient has coexisting DVT PE and the patient requires a PE intervention, it's PE intervention first. On the way out, if there is iliac vein thrombosis on either limb, then we will adjust according for access and do a contralateral thrombectomy of that particular vein by using the same catheter, by the way.
Okay.
And you can do that with some pearls and techniques, whether it be penumbra or with Anari. You can manage and clean the venous outflow. If patient does not have iliac venous thrombus and obviously doesn't have findings of phlegmasia, then I treat with anticoagulation only and reevaluate them in the office setting 2 to 4 weeks. If they continue to have some form or beginning to have symptoms of post-thrombotic syndrome, then I'll schedule an elective thrombectomy for that particular patient. And another sort of question that gets asked in the same sort of concept is when do you not place IVC filter?
Right.
Honestly, the data, the PREPIC trials have all kind of taught us now that IVC filters are overutilized. And if you are using them, they should be retrieved early. But more importantly, unless the patient's hemodynamically unstable, you probably do not require the use of IVC filters.
Okay. Do you see, we see these AI applications we were talking about helping to identify and accelerate triage and diagnosis and even help coordinate care for PE. Do you see that application for these lower extremity thrombectomy and lysis cases as well?
Yeah, well, I think where AI could be really beneficial or some form of technology app is going to be for physicians who are not currently treating this, rather the referring physicians or the patients themselves. The incidence of post-thrombotic syndrome and chronic venous insufficiency is much higher than patients who have, claudication. Yet there's not much focus on this. And I've seen this more often than not. You get admitted with the DVT placed on anticoagulation in the, 3 to 6 months, and they're never managed or followed thereafter. And unfortunately, those patients develop, significant debilitating problems and issues. And, I could see some amazing opportunity for the technology to help target those particular patients and get them treated to, let's say, a center of excellence of some sort. The AI will be incredibly helpful to identify, those extreme patients who have DVT, phlegmasia, or extensive DVT. That certainly can be helpful as well.
Yeah, and I like you were saying, basically, I could really see it being useful for follow-up with these patients too, with some sort of EMR integration. But let's on that topic, let's talk about post-intervention? Who is quarterbacking the care of these patients? It sounds like you have a care coordinator, so that I imagine, and they get them set up in clinic to follow up once they're discharged. Can you talk to us a little bit about your sort of post-intervention follow-up and the longitudinal follow-up that we alluded to at the beginning?
Mm-hmm. So, another take-home point, the longitudinal follow-up is incredibly important for the PE team, VTE team, in that there are a number of patients that need to be managed appropriately with anticoagulation, duration of anticoagulation, as we're now beginning to see multiple data points telling us that even after 1 year of VT, the recurrence rate is still in the double digits, and it can last up to sometimes 3 to 5 years, even for those that don't have an identified thrombophilia. Hence why many of the anticoagulation dosages have gone to low dose or extended treatment. In addition, many of these submassive PEs, whether we treat or don't treat, low risk or patients who have extensive DVT, those patients were not significantly enrolled in any of the DOAC trials with Xarelto or Eliquis or Pradaxa. And so it's my common practice after a PE treatment or a DVT treatment, even if I received adequate thrombus burden removal, I will very often treat and discharge those patients with Lovenox, ideally for a week, if the insurance payers would approve it for 2 weeks, but 1 week is probably enough, and then transition to their DOAC therapy. Now, with Xarelto and Eliquis, they have their loading dosages, so because I am discharging them home with Lovenox, I don't piggyback the loading dosages of the DOAC. I just go to the maintenance dose directly, but that's not based on any data except for anecdotal opinion. And then those patients are seen in the office within about a month. If a patient has a DVT, they have a surveillance study. If they have PE, I don't order an echo until about 3 months, as I'm not sure if the RV comes back and it still, has dilatation or abnormalities, would I do anything differently at 1 month? So why order a test at 1 month?
Got it.
So typically it's a 3 month sort of metric for us. And then depending on the situation, it's either semi-annually or once a year. And we follow them for a good number of sometimes 3 to 5 years afterwards.
And it sounds like your practice covers a pretty large geographical location in that Panhandle area. Is it challenging to follow up with PE patients, that may be coming from even, as far as Alabama or, Louisiana or something like that? Have you had challenges with that?
Yeah, through the COVID piece, we've had now we're, some are 1 or 2 years out and they live over 100, 200 miles away. So telemedicine has been incredibly helpful. And in those particular patients who, don't have the financial means to come visit, or for whatever reason, we will communicate with their PCP and hand them the information. But yeah, that becomes also an obstacle, just like any other sort of facet of clinical care.
Yeah. Well, Rohit, we're coming up on the hour. I wanted to, conclude with any additional advice you'd give to an endovascular specialist in either practice or academics who are interested in forming a team and improve, or even they have a team and they're looking to improve it, make it more efficient. Anything that we've left out in this discussion?
I think we covered most of the aspects within the nuances of developing a team and the management, the high yield sort of aspects. I would just, leave the audience members with an example or two. In the initial, as I mentioned to you before, in the very beginning, when we started the program, it was, the narrative was another sort of procedure for the cowboy interventionist to do. And we made it an intention that this service line was to manage the patient. It wasn't necessarily all about the procedural aspect. We manage, I would say 60% of what we see is medical management. And it's not just medical management from the beginning. It's day 2 follow-up, day 3 follow-up, and office follow-up. And so the team needs to comprise of individuals who are, again, passionate, motivated, and are champions of the respective positions within the PE team. And if there are not any physicians who are part of the team that want to manage that other aspect, then it behooves the interventionalist to learn and do it.
Right.
My IR partner, Chris, he will call me often. Hey, I can't really, evaluate the echo so clearly. Can you look at it and let me know what you think? Or, upon discharge, he will say, all right, I will refer this patient for you for follow-up because the patient has RV dysfunction. And, I'm not sure what I need to look at 3 months. So do you mind seeing the patient in follow-up? And vice versa, I don't remove filters and I'll send the patient to him. So that multidisciplinary team comes into significant advantage when you are thinking about not only initial stages, but obviously long-term as well.
And is pulmonary part of that follow-up process? I mean, are the patients seeing them for, to evaluate, to look at their pulmonary hypertension or anything like that, or are they strictly seeing you?
Right. So I think it depends on, again, the individual physician. So one of our interventional cardiologists is going to come on board of the team. He has no desire to manage patients with pulmonary hypertension. He just wants to do the procedure aspect. So for those patients, it would be probably smart for them to also follow the pulmonologist and outpatient. And then for those patients that we are concerned about thrombophilia or younger individuals, it's a good idea to partner up with the hematologist as well.
Yeah. So basically, wherever you're lacking, you want to find a complementary piece, I guess, is what it sounds like. I mean,
and again, if you don't have, you'll quickly realize that you'll have folks from different subspecialties that want to be a part of the team, but they're not really there for you when you need them, and so it's gonna be dependent on the founders of the team to learn it themselves and to be able to take control of this.
Yeah. Well, that's great advice, and I think a great place to end it. Rohit, thank you so much for joining me and talking through this today. And to anybody that any more resources that we haven't mentioned for anybody that's out there kind of learning on their own, would you be willing to talk to anybody if they had some questions for you?
Yeah, absolutely. It's one of my passions. I really enjoy this piece, and I'm also learning. So I'm often referring to the folks at the PERT consortium who've done an incredible job. And there's all kinds of updated modules and seminars and data. And I often look at that frequently as well. But happy to help and anyone who may have interest.
Great. Thanks, Rohit. And thanks to our audience. You can find all prior episodes on Spotify, Apple, and at BackTable.com. Everybody have a great day.
Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritts, and co-hosts
Chris Beck,
Sabine Dond,
Michael Barraza,
and Ali Behetti.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson,
Josh McWhirter,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson.
And Delaney Aguilar.
Social media and PR by Ann Dang.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening, and see you next week.